Good evening, everyone. We'll start the class now. So, today's topic is overview of shock, and our organizers are Dr. Akhilesh Dandekar, Dr. Gunadhar Padi, and Dr. Asif Iqbal, sir. The speaker today we have is Dr. Debottam Ganguly, who is an associate consultant in critical care, Apollo Multi Speciality Hospital, Kolkata. And the moderator we have here is Dr. DALIM Kumar BAIDYA, who is the professor and head anesthesiology in critical care and pain medicine at AIMS Guwahati. So, sir, it's over to you.
So, hello, good evening, everyone. Myself, Dr. Dalim here. So, today we'll be discussing in brief about the overview of shock. So, Dr. Debottam Ganguly will be speaking on the topic, and we will have discussion on the different varieties of shock, how to diagnose shock, and how to manage shock in different types of shock, as well as in different kinds of approaches. So over to you, Dr. Devottam.
Thank you, everyone, and good evening to all. Today, my topic of discussion is overview of shock. As my audience are mainly exam going candidates, so I am planning to discuss regarding mainly exam-oriented topics. And as we know, we'll discuss of overview of all type of shocks. So the hypovolemic shock or cardiogenic shock or septic shock that will be discussed separately. I'm just trying to focus out important points which is usually missed during our study and we should know prior to going to exam. So it's much more exam oriented topic. I have the slides I have made it. So introduction, as we all know that shock is a state of hypoperfusion state. Uh, so state of cellular or tissue hypoxia resulting from reduced oxygen delivery and or increased oxygen demand or inadequate oxygen utilization. Now, what is reduced oxygen delivery means delivery of the oxygen, as we all know, DO2 depends on cardiac output and as well as the oxygen carrying capacity of the blood. That in turn depends on the hemoglobin level. So if there is a reduced oxygen delivery, that's either due to low cardiac output, like in cardiogenic shock, as well as that could be due to low hemoglobin, like a hemorrhagic shock, or inadequate oxygen utilization that happens in septic shock. This shock, that is low hypoperfusion state, this lead to single or multi-organ failure. Even death is not addressed properly. Identifying the underlying cause of the shock is important as it may need to entirely different clinical pathways or management. So, what should be our approach? Our approach, no. So our approach should be resuscitation and the diagnosis to be done hand by hand. We have to look up the cause of the shock as well as we have to resuscitate the patient. Now, shock window. Window means we have to look through inside our body by this 3 point. We have to check. So next line is important. But shock may not be present in the hypotension. Usually, what happens while we discuss with students, that they usually ask, what is shock? Start with hypotension. But we have to remember that shock may not be present with hypotension. What is the shock windows? Windows means 3 point. One is brain window, one is kidney, and another is skin. Through this, we can detect whether patient is going to develop shock or not. So among patients with all type of shock, altered mental status, decreased urine output, and skin changes are common findings. So these three, we have to check the whether patient having altered mental status or not. We have to look out after the urine output less than 0.5 ml per kg per hour, or skin changes. For example, mottled skin or increased capillary refilling time in hypovolemic and distributive shock, and cold coming periphery in cardiogenic shock. So we have to look after the 3 part. So prior to developing hypotension, these 3 findings can say whether patient is going to develop shock or not. This usually ask in the exam what is the shock window. So try to remember this. Another point is skin mottling. Though in our Indian skin population, the color of the skin is different, so it's different to observe in our day-to-day basis. But again, exam point of view, this is very important question, skin mottling. So we have to remember there is 6 grades, 0, 1, 2, 3, 4, and 5. 0 is no mottling, 1 is moderate, coin-sized, localized to the center of the knee, 2 is the moderate, mottling does not exceed the superior edge of the kneecap, 3 mild, mottling does not exceed the middle thigh. 4 is the severe, that is mottling does not exceed the beyond of the fold of the groin. And 5 is the grave, mottling exceeds beyond the fold of the groin. Now they usually ask the what is skin mottling, what does it define, and what is the score. Now they can ask you that why this happens. So you have to know that there is a heterogeneous vasospasm that occurs around the knee region due to density of the alpha receptor or noradrenergic receptor. Another important topic is capillary refill time. So capillary refill time we used to do in pediatric population mainly. It is a non-invasive, bedside and quick test. Moreover, it is a we can do by anyone can do. No need of any sophisticated machine or technique to do it. Ideally, capillary leaking time should be measured at the bedside by applying a uniform pressure of 3 to 7 Newton for 2 seconds, and response time should be measured with a chronometer. As I told earlier, capillary refill time mainly we used to see in pediatric population, but in Andromeda shock trial, that is the trial after that trial, the capillary refill time came into the picture, particularly in adult population also. So what they did that it is actually done by Latin America, mainly in Latin American countries. They used to do this and they used to run this Andromeda shock trial. And capillary refill time was measured by applying a glass microscope slide to the right index finger at the distal phalanx until the finger was blanched, then maintained for 10 seconds. The time to return to the normal skin color was measured using a chronometer. Important point in this capillary refill time testing, the applying of pressure maintained for 10 seconds after it getting blanched, not from the beginning. We have to give pressure, see the nail bedded branches and maintain it for the 10 seconds. Then we have to see the refilling time. Abnormal CRT is defined as more than 3 seconds. So, but what happens in our population, particularly adult population, the CRT may be increased. Normally, it can be, more than around 3.5 to 4 seconds. Also can present, particularly in elderly age group with peripheral vascular disease. So there is some limitation of capillary refill time, like environmental temperature, skin temperature, light of the room, place of the pressure, quality of technique, all these things. Like in pediatric age group, we used to do in mediastinum. We usually pressure the medius or any bony prominence. The adult we usually do in the distal phalanx, the volar side. Now we should know about Andromeda shock trial prior to exam. Everybody should read about this Andromeda shock trial. So what it defines that what it says that we more look at the lactate level for the prognostication as well as the therapeutic purpose for the shock. What is the recovering stage? What is the stage of the shock? How whether we are resuscitating well or not. So we look the lactate level. But Andromeda shock transfer, we can use capillary refill time along with lactate or alone capillary refill is enough. It is not inferior. It's not superior to lactate, but it's not inferior to. So for the resource limiting setting, we can use capillary refill time for the prognosis to determine the prognosis and the resuscitation strategy of the shock for the shock. Not only that, if you go through the trial details, we'll see that there is a secondary outcome of of this trial, which shows the capillary patient population which resuscitated by the capillary refill time, there is a less volume was transferred to those. So so perfusion pressure improved, perfusion tissue perfusion improved with less amount volume while we are watching the capillary refill time rather than lactate. So lactate clearance is much later. So this group of people get less volume, so there is a less chance of hypervolemia or volume overload related problems. So capillary refill time and skin modeling, these things we have to know prior to exam in details and would go through the Andromeda shock trial. Now, when to suspect shock in a patient? We know low blood pressure, hypotension, tachycardia, oliguria, altered sensorium, tachypnea, cold cami, skin, metabolic acidosis, and bile. Lactate in shock. Another important topic. Lactate we do day-to-day practice in shock patient at the point of care or laboratory testing of arterial, venous, and capillary blood. Abnormal when it is more than 2 millimole. So when lactate level is more, we have to we have to look at the log lactate when it is more than 2. This shock. Severe shock when it is more than value is more than 4. So lactate has prognostic value. Lactate clearance more than 10% associated with good outcome. Now, what is lactate clearance? That is lactate level at admission minus lactate level at 6 hours divided by lactate level at admission. The percentage of this value is called lactate clearance. So, when it is more than 10%, it is associated with good outcome. Now, limitation. Limitation, there is a beta agonist use, metformin use, malignancy, particularly hematological malignancy, seizure, gut ischemia, liver disease. These can, falsely elevated lactate can seen in these scenarios. So, prior to exam, we should know there is a lactic causes of lactic acidosis. There is a lactic acid type A, type B1, B2, B3, and D. So these things we look after the lactate only, lactate total lactate, but there is some subtypes. We should know the causes of each. Better to know. So now in sepsis, high lactate level is not only because of anaerobic metabolism. Next, another thing when usually ask in exam why the lactate increase in stock, most of the students answer that it is because of the anaerobic metabolism. The fact is not totally true. Actually, what happens? Glucose transformed into pyruvate, and this pyruvate transformed into acetyl CoA. Enzyme help in this procedure called pyruvate dehydrogenase. The problem is this enzyme happens in shock. When there is a shock, there is stress and there is a inflammatory mediators. The release of inflammatory mediators. This inflammatory
Devatam, if there is any technical glitch, then are you able to see
yeah,
your
yeah,
slides?
ready.
Okay, then stop. Continue.
So in sepsis, there is a high lactate not only because of anaerobic metabolism, that is maybe due to some problem with pyruvate dehydrogenase. What I was telling that in shock state, there is a release of the pro-inflammatory mediators, which causes the relative, there is a inhibition of the pyruvate dehydrogenase enzyme. So pyruvate cannot convert into the acetyl CoA. Rather, it converts through the lactate dehydrogenase formation of the lactate occurs. So there is an increase of the lactate. Not only that, in shock state, there is a hypoperfusion. So the liver is hypoperfused. So lactate clearance is diminished. That also causes the high lactate level. So we have to keep in mind these points too. Now, what is SpVO2 and CO2 gap? That is another thing we should know. So when end organ undergo anaerobic metabolism, oxygen is taken up from the blood and carbon dioxide is released into the blood, as we all know. Now, venous blood returning to the heart would then have a lower oxygen content and higher carbon dioxide content compared to the arterial blood from very beginning basic biology. Venous blood returning to the heart is assessed around the junction of the superior vena cava and right atrium. And another, what we have to do, we have to take a central line for a shock patient. We usually do the central line, and also we do the invasive arterial line monitoring. So we have to take a venous sample from the central line. So that is when the venous sample, the VBG, actually the PCO2 level in that VBG is PCVO2. So partial pressure of carbon dioxide in the central vein. And SO2 in that sample is SCVO2, saturation of oxygen in the central venous sample. Another thing we have to take a ABG, and we have to look for PO2 level, PCO2 level in that ABG. Now, high demand compared to supply would render the SCVO2 lower than the 70%. When such patient has a circulatory shock, effort to increase supply or reduce demand are warned. A low demand compared to supply would mean that SCVO2 would be the 70% or higher. So normal SCVO2 is 70%. Now, the oxygen comes through the arterial system to the tissue. Tissue takes up the oxygen, and rest amount of the oxygen is required, and rest of the oxygen to be come into the venous side, and which is detected by SCVO2. So normal level is 70%. If it is less than 70%, I mean the SCVO2 is less than 70%. That means tissue taking more oxygen, utilizing more oxygen. There is a more demand in that case. Number one. Number two scenario, when SCVO2 is more than 70%, that is, the tissue cannot utilize that amount delivered oxygen. So it unable to utilize the oxygen. That remain oxygen or excess oxygen come into venous side and detected by SCVO2. When such patient has a circulatory shock, when the SCVO2 more than 70%, for circulatory shock, two possibilities would exist. Firstly, oxygen demand is low owing to the damage of the tissue metabolism, which in turn, due to mitochondrial dysfunction, happens in sepsis or cyanide poisoning, necessitating treatment of the underlying the cause. Secondly, oxygen demand is low due to reduced oxygen extraction by the ischemic tissue in the setting of poor blood flow into the end organ, which can be reversed by improving cardiac output. So the thing is that increase 7 SCVO2 is more than 70%. Why this happens? Either the tissue is damaged, we cannot utilize the oxygen, or the tissue is not that damaged, but poor blood flow, the delivery of the oxygen or DO2 is not improper. So we have to improve the cardiac output in the settings. So how do you know? We are getting SCVO2 more than 70% in both the scenarios. So differentiating these two possibilities requires CO2 gap, which is the difference between PCVCO2 and PaCO2. So CO2 gap would be 6 millimeter mercury or less if the tissue metabolism is damaged, while if it is more than 6 millimeter if the tissue metabolism is preserved within the ischemic tissue. Because ischemic tissue, there is a presence of the viable cells. There is a production of the carbon dioxide which diffuse into the blood, and that is detected by PCVO2. So the gap will be more. Widened carbon dioxide gap is the context of the poor blood flow into the organ is due to continued diffusion of CO2, which has a higher blood solubility than oxygen from the ischemic tissue to the venous blood. So how does this practically implicate it? So signs of circulatory shock, lactic acidosis, SpVO2 is less than 70%. If it is 70%, we have to check again the PCO2 gap. It is more than 6, that is low cardiac output state, or less than 6, then maybe anemic dysoxia. When SpVO2 more than 70% and both 6 millimeter of mercury PCO2 gap, that is microcirculatory impairment that is happening in stagnant dysoxia or severe sepsis. When SCVO2 gap is less than CO2 gap is less than 6, but SCVO2 is more than 70%, that indicates cytopathic hypoxia. Now, biomarkers of shock. in exam they usually ask biomarkers of sepsis, the biomarkers of AKI. This is important. There is another important topic is biomarkers of shock. So what are the biomarkers? As already I have discussed last week, SCVO2 and PCO2 definitely, but there is a new biomarkers also, like growth differentiation factor 15. It is associated with poor prognostic value in patient with cardiogenic shock. Angiopoietin 2 associated with capillary leak in shock. Soluble thrombomodulin or STM predict risk for multi-organ failure and mortality in sepsis patient and risk of AKI in cardiogenic shock. Endothelial glycopalax associated with the vascular endothelial injury permeability in the different type of shock patient. We have to know the biomarkers that would be a uh, short note. Another neglected topic, hemodynamic incoherence. So what happens while the resuscitating of the patient, we are looking after the whether BP is stabilized or not, whether urine output is stabilized or not. But there is a two component in a shock. One is macro circulation, another is micro circulation. The main problem of shock is the low perfusion to the end organ and the tissue level. So we can understand actually the problem is microcirculatory level. But while resuscitating, we are looking after the macrocirculatory level to understand the condition, the microcirculation. But practically, what happens? The microcirculation and macro and microcirculation may not be in same page. So there is a incoherence between micro and macro circulation, and that leads to hemodynamic incoherence. One problem. There are four types of uh, incoherence: type 1, type 2, type 3, and type 4. Type 1 is heterogeneous perfusion of microcirculation, resulting heterogeneous oxygenation of the tissue. I mean, some portion of the tissue is over transfusion. There is perfusion, more perfusion, over perfusion, and some part is hypoperfusing. So this is the heterogeneous perfusion leads to heterogeneous oxygenation. Now, type 2. Type 2 is hemodilution, resulting loss of RBC filled capillaries, causing increased diffusion distance between RBCs capillary and the tissue cells. So RBC is actually the causing the oxygen delivery done by RBC hemoglobin only. So if there is a low RBC, there is a more micro. We have to remember this is all micro circulation level problem. So RBC fills causing the increased diffusion distance between RBC and capillary and tissue cells. This is type 2. Whereas type 4 is when it is done by edema caused by capillary leak. So hinders the tissue oxygenation. And type 3 is the stasis of the microcirculatory RBCs flow by altered systemic variables like vascular resistance. So more vascular resistance, there is more stasis, there is a low perfusion. So stages of shock. So we know about stages. Old thing, compensated shock or pre-shock stage. The body itself attempt to re-establish adequate perfusion and oxygen delivery. There are no overt sign of organ dysfunction. In this compensated shock or pre-shock stage, BP may be normal. So that is the important. We have to keep shock at this level. Decompensated shock, compensated function lost to shock with organ dysfunction. Decompensated shock, there is chance of hypertension. Appropriate intervention to restore organ dysfunction and oxygen delivery can reverse the organ dysfunction in these two phases. Now, irreversible phase. If left untreated in the initial two phases, the patient may undergo permanent organ damage and multi-organ failure. It is the irreversible phase. There is a high mortality and morbidity in this phase. Whatever the type of shock it is, so physiologically, all types of shock go through this three phase. Classification of shock, we all know these things. I'm not going to details of this type of, we just broadly I discuss distributive shock, cardiogenic shock, hypovolemic shock, and obstructive shock. So distributive shock happens in sepsis, neurogenic cause, anaphylaxis, and all these things. Cardiogenic shock, I mean the pump problem, the cardiac problem, and unable to, there is a low cardiac output in cardiogenic shock, myocardial infarction, myocarditis, ventricular arrhythmia, valve rupture, all these things. Hypovolemic shock, we all know, could be hemorrhagic or non-hemorrhagic. Causes obstructive shock, there is an obstruction, and that causes the leads to perfusion to the distal part. So pulmonary embolism, pulmonary hypertension, pneumothorax, tamponade, all these things. So this is the, you all know this chart, I hope, on cardiogenic shock, hypovolemic shock, septic shock. I'll not go details of each point, just to remember these things. The diastolic pressure will be low in case of septic shock. In cardiogenic shock, both diastolic and systolic pressure will be low. So the pulse pressure will be low in cardiogenic shock. Whereas in septic shock, there is a diastolic pressure is very low. So there will be a high pulse pressure. This we have to remember. Okay. And there is a hyperdynamic circulation, particularly in the early phase of the septic shock. So extremities will be warm in case of septic shock, particularly in the early phase. Later phase, there is a chance of cold coming extremity, as we show. Same hyperdynamic circulation causes rapid CRT, capillary refilling time, what is slow in case of cardiogenic and hypovolemic shock. JVP will be high in cardiogenic shock. Crepitation will be seen in cardiogenic shock, so as S3, S for gallop. Chest X-ray is the important we have to do in all shock patients to know the pneumonia, know the pneumothorax, cardiomegaly, cardiac heart size will be diminished in case of hypovolemic shock. Pulmonary edema can be seen in cardiogenic shock. Of chest X-ray will give us good value in assessment or shock. Infection, focus or infection will be present in case of septic shock. Echocardiography will come details regarding echocardiography. In cardiogenic shock will be diminished contractility and ejection fraction. There is ventricular chamber obliteration, echocardiography in hypovolemic shock, missing ventricle sign, important. Septic shock, hyperdynamic function, but septic shock can be, when it's associated with cardiac myopathy, septic cardiomyopathy, then the finding may be different. There is a mixed type of shock in septic shock actually. So advanced hemodynamic monitoring, if you go through this, then cardiac index will be low in cardiogenic shock, and systemic vascular resistance will be high, pulmonary artery occlusion pressure will be high, where SvO2 will be low in case of cardiogenic shock. Hypovolemic shock, cardiac index will be low, SVR will be high, SvO2 will be low, but pulmonary artery occlusion pressure will be low in case of hypovolemic shock. Whereas in septic shock, there is a vasodilation that causes the low vascular resistance. Systemic vascular resistance will be low in case of septic shock due to peripheral vasodilation. Cardiac index could be normal or high due to increased cardiac output, increased heart rate to maintain the cardiac output. Another thing, exam point of view, very much important, rapid ultrasound in shock and hypotension protocol, RAS protocol. We should know right to exam this thing. So point of care ultrasound, focus exam to determine the cause of shock, when referred as pump, tank and pipe protocol. Okay. Help differentiate between different types of shock, including hypovolemic shock, cardiogenic, obstructive and distributive. It also helps guide the next management decision. Acronym HIMAP makes it easier to remember and the different parts of this protocol. H means heart, I for IVC, M for Morrison pouch, A is aorta, and P for pulmonary. Now, what is happened in each step? Pump, tank, and pipe. Pump failure happens in cardiogenic shock and obstructive shock. So, poor contractibility, pericardial phenomenon, all these things mainly pump failure. Cardiac, distributive shock in case of septic shock, like there could be hyperdynamic or hypodynamic depending on the stage of the sepsis. In hypovolemic shock, usually heart will be hyperdynamic. While with tank, that is IVC, thoracic and abdominal components. So tank means the problem with hypovolemic shock. In hypovolemic, there is a tank failure, that is small collapsible IVC, pericardial or pleural peritoneal fluid. And pipe problem is hypovolemic shock. There is a aortic dissection and aneurysm. Okay. What is the tank problem seen in the, this could be seen in the distributed type of shock. Now, critical care echocardiography driven approach to undifferentiated shock. It's an important question in exam. It usually asked in theory cases exam the echocardiography driven approach in undifferentiated shock. So, particularly those who are DRNB candidates, you should do echo bedside regularly because they in practical exam they used to ask to show all these things. No, to do this echo, and you have to show the five chamber view. You have to show the LVOT and measure the VTI. So first we have to do obtaining an apical five chamber view to assess velocity time integral in the left ventricular outflow tract, which is surrogate for stroke volume. So VTI means that stroke volume. So normal VTI measurement range is 18 to 22. VTI is severely decreased when it is less than 16. So VTI less than 16 means there is a low stroke volume. This is the first step. Second step in this algorithm is to evaluate the right atrial pressure. Right atrial pressure, how can we see? We can do it by seeing the inferior vena cava assessment and limited visceral organ Doppler, LIVOD. This limited visceral organ Doppler happens when there is an indeterminate finding of the IVC, inferior vena cava. Right atrial pressure considered to be low or normal when IVC diameter is less than or equal to 2.1 centimeter and has greater than 50% collapsibility, as we all know. It is considered high when IVC diameter is greater than 2.1 centimeter with less than 50% collapsibility. Now, next step, we have to perform the LIVOD interrogation is appropriate, as I told earlier, when the IVC diameter and collapsibility is intermediate. The LIVOD assesses the hepatic venous flow pattern, which is closely related to the central venous flow pattern. An increase in the right atrial pressure is considered when S wave becomes less prominent than the D wave. And even a reversal of the S wave can be seen with severe RAP elevation. I'm not going to details because it is a separate topic, it's a huge topic. I just going through only regarding the important to the shock stage, but you guys should know how to do this. Now, third step in this algorithm incorporate the lung ultrasonography finding that includes patterns such as pneumothorax, interstitial syndrome, pleural effusion, alveolar syndrome. For example, an increased number of B lines, usually greater than 3, can suggest pulmonary edema and elevate left-sided filling pressure. To understand what I have told, so first we have to check for VTI at LVOT to know the stroke volume status. Okay. Then what we did the IVC parameter, check the IVC level status, and then we go for the lung ultrasound. These three we can do at bedside. Any of to understand what I have to better understand, I have introduced a case scenario. So a 60 years old man who is recently recovered from COVID infection presented with 2 weeks of progressive orthopnea and dyspnea with minimal exertion. Now, in the emergency department, he received 5 mg of intravenous metoprolol for atrial fibrillation with a rapid ventricular rate of 170 per minute, beat per minute. The patient then became hypotensive with blood pressure 88 by 56 and his extremities were noted to be cold to touch. So he was transferred to the intensive care unit in overt respiratory distress. Critical care echocardiography was performed, which revealed poor biventricular systolic function, determined by visual estimation of ejection fraction. LVOT VTI was reduced to 12 centimeters. So there is a stroke volume limitation. IVC diameter was 1.9 without respiratory phasic variation. So no variation 1.9. So that indicates CVP around 10 millimeter of mercury. As it is inconclusive, we have to look for hepatic vein status, systolic flow reversal consistent with the increased right atrial pressure because there is a lack of severe strike capsule regression in this patient. The lung ultrasound showed extensive B lines in the upper lung field, which suggests pulmonary edema and elevated left-sided filling pressure. So cardiogenic shock resulting from acute or chronic systolic heart failure, volume overload, and fluid intolerance was diagnosed. This is the echocardiography, how we approach a patient with shock with echocardiography. But apart from this cardiogenic cause, we have to look after during exam actually, particularly exam purpose, you should write down the other finding also, like what happens in PE, what is the echocardiogram of PE, if it is obstructive shock, what is happening in cardiac time node, all these things have to be incorporated. But this algorithm we should know. Now come to resuscitation. How do you resuscitate a patient with shock, any kind of shock? As I told earlier, evaluation and resuscitation will go hand by hand. So we should know 4D and ROSE protocol. I come to later. Use dynamic hemodynamic monitoring for the assessment of fluid responsiveness. Appropriate vasopressure according to need. Management according to the type of the shock and underlying the cause. So ROSE protocol. R for resuscitation or rescue, O for optimization, S stabilization, and E for evacuation. So resuscitation is aim of the fluid treatment is resuscitation and correction of the shock to achieve to target to adequate perfusion pressure. It is the first phase. Next, the target to be fluid should be administered according to individual need and reassessed on a regular basis. So that is the purpose of the optimization. So a patient with cardiac failure, like a patient with known systolic dysfunction, cardiac dysfunction, LV dysfunction, patient ejection fraction of suppose 30%. But if this patient present with shock and there is an indication is dehydrated or there is a need of fluid, we have to give fluid. We have to resuscitate the patient. And then we have to monitor the patient, whether it is helpful or not. We have to administer first is resuscitation, then optimization and stabilization is the next step. Aim to provide the water and electrolytes to replace ongoing loss and provide organ support. Now, last step is evacuation phase. That is removing of the excess fluid, which will be frequently achieved by spontaneous diuresis. Itself, patient can diuresis. We do not chase the fluid. Usually, what happens in day-to-day practice, those that don't know the things, so usually give them more fluid during this phase. We have resuscitated enough. We have push the fluids inside the body. Now, body itself we pour out the excess fluid. We don't need to chase the fluid. It is a phase of evacuation phase. That is frequently spontaneous recovery patient, although ultrafiltration diuretic might be necessary. So, at that phase, we have to patient in the negative balance. It is generalized point, all type of shock, but it will be changed slightly according to type of the shock, right? So, ROSE protocol is an important question for exam. Another is 4D. 4D actually comes in the antibiotic, but later we can in fluid therapy also we use this terminology. Fluid is a drug. One is 4D is drug, dose, duration, and de-escalation. So drug is hypo or hypertonic, high or low chloride sodium level, lactate, bicarbonate, vapor. Depending that we have to choose the fluid. But the dose depends on the type of the fluid. Glucose containing, crystalloid, colloid, this osmolarity, oncogenicity, kidney function, all these things we have kept in our mind. Now, duration. So, how many days we'll go do with this? So, fluid can be stopped when shock is resolved. Do not use fluid treat low CBP, MAP, or urine output, but use fluid to treat the shock. When there is a need, we have to give fluid. When there is no need, then do not give fluid. So there is no strong evidence that trend towards shorter duration. De-escalation after stabilization with early adequate fluid management and stop ongoing resuscitation and move to LCFM, that is late conservative fluid management, and LGFR, that is late goal directed fluid removal. Early goal directed therapy, now it is LGFR, that is late goal directed fluid removal. So target to negative fluid balance. Okay. So this is the approach. Now I'm generally just with the chart I trying to explain what happens. The clinical condition consists of shock. If it is yes, we have to secure airway if it needed. establish IV access, blood draw for lab, all type of, when we're thinking septic shock, we have to go for all the parameters needing for sepsis. If it's the cardiogenic, we have to check the cardiac enzyme and all. So accordingly that, administer fluid bolus. Is life-saving or early intervention needed? If it is yes, then we have to take the history examination, focus with administration of life-saving maneuvers or early intervention, like ICD for pneumothorax, peak tail for cardiac tamponade, IV adrenaline for anaphylaxis, antibiotic for sepsis, steroid for adrenal crisis, like this. If patient is stabilized, if it is yes, then we have to again focus on clinical examination and history, and according to we have to manage, resuscitate the patient. And if it's not, then we have to again this, we have to recheck and redo the, continue the resuscitation. Now last slide is quite cloudy and clumsy, but it is a compact slide actually, so I have put it. So if there is an undifferentiated shock, whether it is a pump problem, that is low cardiac output, or pipes problem, that is low SBR, and tank problem, that is low preload. So if this is a pump problem, that is either it is could be cardiogenic or obstructive. We know all this: right ventricular failure, left ventricular failure, valve problem, trauma, rate rhythm, bradycardia, arrhythmia, all these things come under cardiogenic shock. In obstructive shock, there is a tension, pneumothorax, cardiac tamponade, pulmonary embolism, outflow obstruction, all these things. In pipe, that is distributive shock. Important: sepsis, anaphylaxis, okay, endocrine, adrenal insufficiency, all these things come under distributive shock. And hypovolemic, hemorrhagic shock, trauma, surgical trauma, GI loss, diarrhea, vomiting, renal loss, all these come under hypovolemic shock. Now, I have discussed this portion, but again, it is as it's compact, it is important to figure it out. Heart, IVC, lung, skin, neck, what happens in cardiogenic, obstructive, distributing, and hypovolemic shock. So this is the good slide. A pattern, I mean, we can say that pleural effusion in case of left ventricular failure. There is increased JVP in case of obstructive and cardiogenic shock. There is a flat neck vein in hypovolemic shock. These things we need to know for approach for the differentiated, undifferentiated shock. So that's all from my side.
Thank you, Dr. Debottam. I think you presented very well. Particularly, you spend good time on topics which are a bit difficult to understand and comprehend for the trainees. So I think we can take questions. So there
Yeah,
are a few questions
so
in the chat box as well. Yeah.
I have few points. So it's a very good presentation. I'm Dr. Gunadhar from Apollo Hospital, Navi Mumbai. So it's a very well presented, and I think summarization is very good, and it is the practical tips what he has given, Dr. Debottam. So most of the times in the critical care unit, the challenge happens because of failure to recognize the shock actually. That is the most important thing. Most of the times the patient looks stable, but actually the patient is in shock. The BP may be normal, but the patient may be in the shock. So that time the early intervention sometimes helps. Like what Dr. Debottam pointed out, that normal BP doesn't rule out shock. So shock is basically the under perfusion. That is the very important point which needs to be understood by all the exam going. And under perfusion means either it is a low circulation, or either it is a inadequate oxygen delivery, or it is because of the low cardiac output. So these are the three things. So any form of under perfusion will manifest in the form of either your elevation of the lactate, low PO2, metabolic acidosis, tachycardia, or you can say like cerebral dysfunction or any organ dysfunction, cold and calm your capillaries, and underperfused skin in the form of mottling. So this is thing. So I like sometimes the patient. So and it is very important to recognize the stages of the shock, at which stage the patient is, whether it is a compensated and decompensated. Because most of the intervention what we do in the decompensated stage, particularly I'll tell you regarding cardiogenic or septic shock, they are actually futile. You don't get any good results. That is why the earlier intervention, it is always better. It is the time is the your tissue, and time is your very precious. That is why the shock window is very, very important. What other point I would like to highlight regarding the shock index? So shock index is basically nothing but it's the heart rate divided by systolic blood pressure. So most of the times, if you get a shock index more than one, sometimes you can say, and it is a progressive, and then it is you can say that the patient is going towards the deterioration. Early compensated, of course, many interventions are very, very important and it should be done early. If your patient is in cardiogenic shock, you have to put an IBP, you have to start ionotropy, you have to do an ECMO. Once that same patient goes into progressive shock, irreversible shock, decompensated stage, most of the interventions are futile. Sometimes another point is like clinical pulse. Sometimes the patient who is having hypertension for a brief period of time in the cellular level or under perfusion the cellular level, the effect may be seen after 4 to 6 hours. Suppose a patient of cardiac patient having a ventricular tachycardia and patient is having shock, patient may be stable for a brief period of time. After 4 to 6 hours, you may find a rising in the lactate and decrease in the urine output. So sometimes that's why do not jump into the conclusion. You have to see the trend always. See the trend in the long term. So long run means I mean to say over a period of 4 to 6 hours, 12 hours, or sometimes 24 hours. Do not jump to a conclusion that the patient is absolutely normal. So that is what most of the times we mistaken, but it is not likely that. So always assess this patient. Assessment in the form of either you think for a microcirculation assessment or microcirculation assessment, whether you put your hemodynamic monitoring or you monitor in the form of your urine output or your perfusion of skin perfusion mentation, or whether your high blood pressure and other things. So that is what is a very, very important concept. And lactate clearance, what is suggested, you have to see the trend of the lactate. One lactate doesn't carry any significance. You have to see the trend over a time, whether the lactates are getting cleared, the acidosis is getting cleared, or there is a worsening. Always remember the kidney perfusion is one of the earliest and the best indicator for the shock. The first sign of any kind of shock is a immediate decrease in the urine output. Even if the patient looks stable, if the patient is going into oliguria, unless until there is some kidney issues or patient is on diuretics or some other things like where you can have a some kind of false value, the kidney perfusion is one of the best indicator of you can the shock. That is why most of the trainees, they should not forget to ask for the urine output and look for the bedside simple clinical parameters like capillary refill, urine output, your mottling of the skin, sometimes the your temperature of the skin, the periphery to temperature difference between the central and the peripheral temperature difference. These are the very, very subtle signs that will tells you that the patient is actually going to be in the shock. So it's not only the blood pressure, it is the global assessment. Always assess the patient globally. That is what the take home point here is in this lecture. Actually, it is a very, very important topic because 90% of the critical care patients, I feel that this assessment is most of the times it is missed assessed by most of the expert clinicians also sometimes. That is where is the challenge. And I think well presented. And let's take the questions.
Yeah, well
Thank
said,
you,
Dr.
Farz.
Gunathar.
Yeah.
So basically, especially in hypovolemic shock, till your stage phase one and phase two type of shock, hemodynamic parameters doesn't change at all. It's only in the third stage or the fourth stage the patient becomes symptomatic, the heart rate changes, or the blood pressure changes, or the urine output change is obvious. So that's why it's a dynamic process. The patient in a shock, his condition is going to deteriorate. And most of the times, what we see, even if the patient seems to be responsive, he may not be responsive to the fluids. And we keep giving fluids overzealously and end up with fluid overload, because fluid is also like a drug. Anything we use, whatever interventions we use, these interventions have got some implications, some positive implications, some negative implications. But if we don't monitor our patient bedside, these positive outcomes can get into a negative outcomes, and the patient is likely to deteriorate. So that's why we need to monitor this patient, especially in this window period when the patient comes up. we need to monitor the patient, and we need to be very vigilant. And it's not like when the bus is gone and you try to fetch the bus and you try to do all the interventions, then all the exercise is futile. So that's why time is very important. Timely interventions or any kind of therapy that we advocate, these are very important. So that's all, but it was nice presentation. And we can take some questions, Dr. Asif. Yeah.
Thank you,
Yes,
Gunadhar.
sir.
So I will request Dr. Dalim to check the chat box, and there is a lot of question given during the
Yeah,
session.
yeah.
Dr.
Yes.
Dalim, can you address this question,
Yeah,
please?
yeah. So, I can see a question from Dr. Aldo that most likely cause of persistent shock, and what would be the next best step in management? So, persistent shock or maybe refractory shock is mostly will be there. Either you should consider in those moments a misdiagnosis, or it may be because of a late presentation. For example, in hypovolemic shock is usually diagnosed easily and treated and cured much more quickly compared to a cardiogenic shock or a septic shock. So when you have started resuscitating a shock and initiated maybe fluid boluses and vasopressors as well, but if the patient is not responding, then you may need to do some more intensive monitoring in terms of characterizing the severity of the shock, and secondly, doing a thorough check on the etiology aspect of the shock as well. For example, commonly in a septic shock scenario, you may miss a underlying cardiogenic component of it, maybe an RV dysfunction or an LV dysfunction underlying. So use different tools which Dr. Debottam has discussed. For example, a biochemical parameters like lactate, SCVO2, CO2 gap, all these aspects. And at the same time, a very good tool is point of care ultrasound. So today we had less time, but in that time he talked about the RUS protocols, the pipe tank and the pump concept. So if you characterize, look at all these etiologies and find out the exact underlying cause, then you may take a better decision as to what should be the next step in the management. Anyone, if wants to add anything more, please go ahead.
Yeah, that's okay, Dr. Dalim. You can go ahead with the next question, please.
Yeah. So next was by Pallavi Bojja. Please explain the flow chart of signs of circulatory insufficiency. So, Pallavi, if you're here, which flow chart you mean to say, the SCVO to CO2 algorithm, or the anything else?
I think actually there is no particularly flowchart for the circulatory insufficiency organ wise, but the lactate is one of the important thing. The urine output lactate and the skin, yeah, the capillary refill
Capillary
time
refill time, yes.
is more important to get the overview of underlying microcirculation deficiency. Gunadhar, you want to add anything on this?
No, no, I think you are right. So the you can make your own flow chart. There is nothing. I don't think there is any particular guidelines or flow chart available. So either you can go as a compartmental model, like you can either go for the central and peripheral compartmental model, or you can go for a biochemical parameter in the form of lactate, bicarbon, their acidosis, your PO2, and you can also go as a organ failure assessment, particularly from the brain, kidney, heart, and your skin. So in this way, you can make your own flow chart and serially monitor the trend and actually come to a conclusion whether the shock is happening in the microcirculation level or it is happening in the macro circulation level. You can add the hemodynamic assessment also in this. So another very important point what I just realized here is, see, basically the compensatory shock is sometimes give you a lot of time. The patient, if the patient is young, if the patient is having a very good body reserve, you can find the compensation compensated phase can last for some time, 24 hours to or more than that also. But once the decompensated phase starts, if the patient has a very poor reserve, particularly elderly, lot of comorbidity, and if the shock is like rapidly progressing, the decompensation happens very rapidly within a 2 hours, within 4 hours, or within 6 hours. The patient may go into cardiac arrest. So that is the reason. So you have to block that vicious cycle because you have a sufficient time in assessing the patient in the compensated phase, but you don't have any time in while assessing the patient in the decompensated phase. So that is why is the challenge in most of the times we face actually. That you have to remember actually. So whatever you do, your flow charts, your assessment, your hemodynamics monitoring, everything is like you have to do earlier in the compensated phase till the shock become irreversible or your progressive. That is what the take home point.
Yeah, I would like to add a few little, one or two more points. Like we are becoming very gadget dependent, and all these fancy gadgets are available, and we have forgotten our clinical tools. Though the clinical tools are, bedside, you have easy accessibility, you have reproducibility, you have, no time which is lost while assessing the patient. A simple touch and a simple monitoring of the heart rate, patient's blood pressure, patient's skin turgor, urine output. These parameters are very, very relevant till now also. Though it has a 50% sensitivity, 50% of the chance that the clinical parameters may be right, but 50% of the chance, that chance is also still significant. But yes, you should also take the help of a CVP, pulmonary capillary wedge pressure. You have 2D echo parameters, LVOT, VTI index. You have IVC collapsibility, IVC distensibility. You have microcirculatory parameters, lactates, and you have global perfusion assessments. You have impedance techniques which can also give you assessment of the perfusion related abnormalities, microcirculatory abnormalities. So no one gadget is really foolproof. You have to consider one or the other parameters together and draw some conclusion, because even if you go with the lactate elevation may be abnormally elevated in various other non-shock conditions also. So we should not just get guided by one parameter, and we should see the trend of these parameters, whether the parameters are increasing or decreasing. So that trend is very important. Say for example, CVP also. How many of us really follow CVP nowadays? We don't follow. But if you see the CVP trend, that also gives you a lot of idea about what's going on with the patient as far as the perfusion related abnormalities are there. So that's why we should not depend upon only one gadget or one
Yeah.
parameter. We should have a global assessment, and multiple parameters should be assessed together to come to one conclusion. So that's all from
Okay.
my side. Yeah.
So only
This.
I want to add for all the student one thing for your practical exam, whether you are giving DRNB or DM or and the ADIC also, you have to know very well uses of ultrasound because in any shock case the last exam happened in the ADIC. There also they have given one cardiogenic shock scenario, and they ask everything about your utilization of the point of care ultrasound to diagnose shock, and what will be the chamber size, contractility in particular, any findings for the particular shock. So it is very that's why Devottam has given a very good slide on the USG utilization of the echocardiography to diagnose shock. Please go through the focus. Any book have the findings, so उसका एक बार रट्टा मारना है boss before going to exam, whether you are giving DRNB or DM or ADIC, you have to know the all about the focus. So, Dalim, you want to
Yeah.
add anything?
Yeah, regarding focus, I think you have rightly said, but it's very difficult to memorize things unless they are doing it in their routine daily clinical practice. So I suggest you all need to, in the beginning phase, may need to attend some workshops at least a couple of days, and then start doing focus in your daily clinical practice. Then only will internalize all those things. There are a couple of questions on ultrasound as well here in the chat box. Dr. Hendra asked about the role of IVC ultrasound in hypervolemia in fluid therapy, and there is another question by Alagi, a general question about how to ultrasound examination for a patient in shock. So, Dr. Debottam already talked briefly about it. To answer regarding IVC, yes, IVC ultrasound is something which is done almost very regularly in a patient of shock, but you need to know the limitations. In extremes of findings, like a very small diameter or a very large diameter, IVC will give you a good amount of information. But in the in between phase of IVC, particularly when there is no associated collapsibility or distensibility, may mislead you. So, in a setting of hypovolemic shock, a very small caliber IVC with good respiratory variation almost surely points that you are dealing with hypovolemia. Whereas in a cardiogenic shock, if you have a very dilated IVC with no variation at all, then you are almost sure that you are dealing with a cardiogenic shock. But there are certain fallacies and limitations which you need to, read through and understand. And generally, for ultrasound assessment in shock, I think RASH protocol is the most important, which Dr. Debottam has talked about. But remember that RASH protocol is for initial approach to a patient of shock. That is for the first time when you're assessing a patient of shock, mainly to do the etiological diagnosis. But sequential, you have to follow it up with specific, clinical questions when you want to do the decision making. For example, you when you have the decision to take whether I need to give more fluid or not, so then you have to examine the IVC, the cardiac chambers, maybe the lung fields also, to find out the answer. Similarly, when you need to know whether I institute a vasopressor therapy or increase the vasopressor therapy or an inotrope, then you need to examine the cardiac chambers again in finer details like contractility in the eyeballing, or if you can do velocity time integral, what Devottam has talked about, then it will give you better idea about the patient's clinical condition. So anyway, POCUS is a detailed topic for as much as 2 days workshop. It's difficult to talk about all those things in a nutshell, but more important is that you just need to hold the ultrasound probe and start doing it in your regular clinical practice. That is the way I think.
So basically in the exam, for DNB exam, basically you may be like the bedside, the examiner may want you to demonstrate by the ultrasound machine. Sometimes you may get echo and ultrasound machine by the bedside when you are giving the long case. So practice it and be well versed with all the protocols, like whether it is a false, blue, rush, CASA, or it is like your focus, whatever the thing is that, and different
Now,
different
Vexus is
windows.
also an addition. That
Yeah,
also we
yeah,
should
yeah,
know.
yeah. And all the windows like flax view, sax view, your four chamber, two chamber, your everything like BTI. So all these things you need to be well versed, because at least you have to have a eyeballing assessment and you have to show the examiner that actually you do the things practically in your ICU. Actually, this is now more and more the exam pattern is now they are now converting to the bedside and mostly clinical oriented. So you need to know and need to practice it actually. So you may read theory, but when you want to demonstrate in front of the examiner, then that time you may not you fumble or you may not be confused. That is what the most important point. Okay, so this is what.
It is actually, I think it's a must do practicing UCO. And in my exam, in practical examination, it was told me to do the echocardiography and show the LVOT, BTI, and five chamber view, four chamber view, all the things. So I will ask my juniors definitely to practice bedside focus and including echocardiography. get to the practice unless otherwise in examination that day it will be difficult.
Get well versed with
Okay.
the nobology of the machines. Huh? Most of the times we fumble doing these
Yeah,
machine
we're
handling,
using
and we
one
don't
kind
know
of
what knobs
one
we are
comp.
handling. Yeah.
Yeah, the company is various.
I think Merry Christmas to all of you. That today is the Christmas Eve. In spite of that, the student is very enthusiastic. Everybody is still waiting. So, Gunadhar, let's give a
Yes, 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 yes. Yeah, yeah.
thank you,
Mm.
Devottam. Thank you, Dalim
Thank you,
Bhai,
sir.
as a
Thank
great
you,
thing.
everyone. Thank you. Good night.
Thank
Yeah,
you.
Thank you,
Thank
thank you.
Gunadhar,
Thank
and thank you, Achilles.
Thank you, Dr. Dalim. Thank you, Asif, Dr. Asif,
Thank you.
and
When I
everybody.
put this 24th, I thought कि everybody हमको गाली देगा. देखो अखिलेश पार्टी पार्टी
I
मनाना
already
स्टार्ट
have
कर
the
दिया.
Christmas celebration. I am already in that position.
Okay,
So,
okay. Merry
so
Christmas to you.
Merry Christmas, everyone. Bye
Yeah,
bye.
happy
Good night. Good
Christmas.
night. Good night. Good night.
Thank